I think one of the other questions I know I've gotten from patients when they've come for second opinions, and I know Dr. Armstrong and Dr. Gayard, you do quite a few second opinions, especially with regards to available clinical trials. And patients say, well, I have my doctor at home who I really like, and I don't want to leave my doctor, but what happens when I'm on the clinical trial? Can I get things done locally? Like, how do I balance all this? So how do you advise patients when they're trying to figure out that piece, when they have a really good relationship with their primary doctor, but maybe they're in a community center where there aren't clinical trials and they're coming to a tertiary center for a clinical trial?
Yeah, so it's a partnership, and certainly something that the clinical trials that are being done at that center, and most of the time, the infusion for the drugs and the other key parameters or key parts of the study cannot be done elsewhere. They need to be done at one of the sites that's participating in the study. And sometimes it may be a study that has only one site or a handful of sites, or sometimes these larger studies may have many, many sites, but you do need to go to a site that is participating in the study. At the same time, though, if someone is traveling for a study, so often during that time that they're enrolled in the study, I'm taking over their care during that time frame. But if someone is traveling for the study and they're not immediately local, then it's really a partnership with the local oncologist, because I need eyes and ears closer to the patient. Because if the patient develops some sort of problem that might be a side effect of the drug or a complication of the drug, then I want them to be seen by someone who understands what cancer therapy looks like and what toxicities of cancer therapy looks like. And so I always try to make sure that I'm engaging the local oncologist, that they're aware of and part of the partnership, because I do really rely on them during that. And most of the time, patients will go back to receive standard therapy after the study with their primary oncologist.
I would also agree. I think, I think both Dr. Wethington, Dr. Gayard, and I, and Amy now, because she's so well established, we get emails from doctors outside who have patients, and they're at a transition in terms of their treatment, and they want to know, is there a clinical trial? They're trying to do the best for their patient, and so we usually will send it to Amy and ask her because she's the font of all knowledge when it comes to eligibility requirements. But for most of the doctors in our community, they really want their patients to be able to access care, even if they don't get it through them. I mean, we have lots of our patients, for example, who may go to the NIH for a clinical trial at some point in time. Or I have some patients who may go up to Memorial Sloan Kettering or Penn for a trial, because we've figured out that there's something there and that they're interested in. And so that's usually not, I mean, for the patient, it can sometimes be that travel and that distance is an issue, but I don't think there's a lot of territoriality between doctors. We all want what's the best for the patient. We also don't want people, to feel like you're going to have to handle the problems and toxicities of this treatment that we're giving. But so it's really a very much hand-in-hand thing. But if you have a patient who's 2.5 hours away, who's getting a therapy, and they have something sort of acute, you don't want them to be driving 2.5 hours. You want them to be seeing somebody local. So it really is usually, a hand-in-hand thing that we work with the local oncologists that patients have.
I think to end, because we're at the very end, and I always want more time, so I apologize that we're at the end, but I want to end with what I think is a very conceptually important question to our patients. And actually, Dr. Gayard, your analogy is wonderful, and a much better, the stars aligning is a much better analogy than my needle in the haystack analogy that I chose for the title tonight in terms of the matching. And I chose the needle in the haystack analogy because I feel that even with all the trials we have at Johns Hopkins and at many institutions around the country, we have seen a decrease, actually sort of numerically, in the number of GYN cancer trials available to women. And so sometimes there'll be somebody who's interested in a trial and we can't quite find, finding the right trial for them is a little bit like a needle in a haystack. And so I've had many patients over the years ask me, well, what can I do? How do I, there aren't enough trials for GYN cancer patients. Sometimes they'll name another disease site and sort of longingly say, well, that disease site has so many trials. And my disease site is so important. And it doesn't seem to be getting the attention. And so I sort of want to end on that in line with the theme of the month of awareness for GYN cancer, sort of if a patient says, what do I do to increase the number of GYN cancer trials, or what are opportunities, or why is this, by the way, and what can I do about it?
So I'll start, and then anybody can chime in. One of the things is being vocal and talking more about cancer, about specific cancers, of supporting organizations that are doing that, both doing research and promoting clinical trials. All of us as who are academics at Hopkins are promoting clinical trials. We're educating patients. We're educating people beyond the institution. I participated and moderated a session yesterday for something called the Women's Health Innovation Summit. And it was actually really interesting because it brought together people who are developing investment funds for pharma, developers of different technologies for diagnostic approaches, and then somebody involved in artificial intelligence and big data and all of that. And the whole summit was all focused around how do we boost interest and participation and focus on women's health. And this particular roundtable was on oncology specifically. And so the word is getting out there. I think we need to do more of it. And a lot of that comes from just speaking out at all different levels, from the patient level, making your concerns known through different advocacy groups, at the academics level, at the local oncology level, saying we need more of these trials, at the national cooperative group trials levels. So really just trying to speak out and get more focus, more attention on these diseases.
Dr. Wethington can maybe talk a little bit about the like Stride to Thrive and some of the fundraising that we do at the local level. There are two organizations, the NOC, the National Ovarian Cancer Coalition, and then OKRA, the Ovarian Cancer Research Alliance. And both of those are national organizations that are sort of grassroots organizations, but that advocate for clinical trials and other support for women with ovarian cancer. And I will point out that that one of the largest ways of funding ovarian cancer research is through something called the Department of Defense. And it's a long story about why the Department of the Defense does this, but the funding for that has to be reallocated every single year. And both the Ovarian Cancer Research Alliance and National Ovarian Cancer Coalition, they go to Capitol Hill every year and they pound the pavement and they talk to the folks who make this decision. And touch wood, we have been able to go up from our basal of about $20 million in ovarian cancer research a year to $30 million, even in the current climate. So that's really a testament to the survivors that work with this group, with these groups. And so there's certainly, I think, you don't have to go up to the Hill, but there's certain are things about writing your Congress people and things like that that you can get involved with if you're interested in advancing research into ovarian cancer. And I think both of those organizations would be good places.
And beyond ovarian cancer, I'll just tout the Foundation for Women's Cancers that does focus on other GYN cancers as well. And that's a great starting point for identifying other ways of promoting further emphasis in this area.
Yeah, I think those are all great ways to end. And I do have a special place in my heart for our own survivorship program here at Johns Hopkins. And as you can tell from these webinars, it's a passion of mine and something we are trying very hard to spread awareness. So we do have normally our conference every September, which we obviously can't have this year. And then we have a race every spring to raise awareness and raise funds to help fund our research program here. So at the Johns Hopkins local grassroots effort, that is what we focus on, and we work with the Women's Cancer Foundation and with NOC and with OCRA very closely, and are very fortunate that OCRA has supported our woman to woman programs. So all of these programs are sort of key institutions. So there's lots of opportunity. Thank you guys so much. I promised I would end on time, and I'm only 5 minutes, but I was right that we could keep going for much longer. So,
so just as a follow-up to my introduction, if anybody doesn't know who Jerry Mathers is, Jerry Mathers is the actor who played Leave It to Beaver.
That's right. I had forgotten that.
Jerry Mathers as the Beaver. That was the introduction.
Absolutely. That's fabulous. Well, thank you, everybody. Have a very good night. And we hope we see you next week, where we're going to do a session on mind matters. And we're going to focus on different mind matters. So we're going to have one of our chaplains, Rhonda Cooper, on. We're going to have a therapist on with us. And we're going to have someone who specializes in neurocognitive effects of chemotherapy. So a very interesting, eclectic session of topics that all meet because they all affect our minds. So we'll see everybody next week. And thank you again, everybody.